Hello, welcome to the EKG Guy. If this is your first time. Here we're going to get back to our EKG of the week, okay? In this EKG of the week here, we have a patient that's presenting, a 47-year-old male found unresponsive on the street, and you have this EKG when you first see him, okay? So what you want to do is pause the video, take a moment, try to go through everything here on your own, okay? On the right side, the regularity, rate, rhythm, origin, ventricular axis, atrial conduction, AV conduction, IV conduction, waveforms, okay? And then is there anything else for the R wave progression and transitional zone? Try to come up with an interpretation on your own, okay? And then I'll give you the comparison to a prior EKG, okay? So pause the video when you're ready, start it, and we'll go through this together. All right, hopefully you had a chance to at least do as much as you could, all right, and trying to approach this on your own. So let's go through this. First, this is the approach that I use, and I think this is the most helpful. I mean, you'll have other people that are biased to their own approach, but this allows me not to miss anything on the EKG, and it's really held up quite well. So if you don't have an approach, then you could use this. It takes sometimes a little longer initially when you're starting, but that's the way it is when you're learning something new. So let's get going. So the regularity, when I ask if the regularity is regular or irregular, I'm looking at the intervals between different waves or segments, okay? So what you want to do here, and the easiest way, are to use these R waves, okay? So this is an R wave here, the first positive deflection of our QRS complex, and here's the next R wave. This is called an R to R interval, from one R wave to the next, okay? And if these intervals between each of those that follow are the same, okay, so all of the duration of these is the same, we would call that a regular rhythm. If it were not the same, okay, then we would call it an irregular rhythm. And if it was irregular, then we have to figure out if it's regularly irregular or irregularly irregular. Now, thankful enough, we won't get into that now. This is a regular rhythm. So this rhythm here is regular. Okay, so you would put regular here. Okay. Now, why is that important? Because there are many ways that you can find the rate, okay? But there are only certain ways you could use some of these ways if it was irregular, okay? So I'm going to show you both ways in this case, and then tell you which one you could use when it's irregular, all right? They're both quite easy, and you may have heard of each of them, okay? We won't go into too much detail on them. So you want to find an R wave that falls near one of those thick lines, or you can use an S wave. And the same thing for the regularity. You could follow these P waves throughout, and to see that all of these P waves had the same interval, we call that the P to P interval. Now, an R wave that falls near one of those thick lines is probably this one here. Okay, you can see it right here. And you want to find the next R wave, which is this one here, and count the number of thick lines between it. So 1, 2, 3, 4. So just over 4, so between 4 and 5. And what you would do from that point is 300 over 4 equals 75, okay? And then 300 over 5 equals 60. So it's somewhere between these two. So as you can see, this is the 4 thick lines that I got here, and the 5 just beyond it. It's closer to the 4, so it's probably closer to the 75. But the rate is somewhere between 60 and 75 beats per minute, okay? The next thing you want to do for finding the rate is another way in which you have to know that the duration from beginning to the end is 10 seconds. Okay, so every 12 standard lead EKG that you have, so this is a 12 lead EKG, it's standard, it's 10 seconds in duration, okay, and then you would do 10 seconds times 6, which is 60 seconds, okay, so that's if you had 6 of these, so imagine that one of these is 10 seconds in duration. If you had 6 of them, 4, 5, 6, that would be from beginning to end 1 minute. Okay, and what you want to do is count the complexes on these, all right? And if you were to count the QRS complexes, which represent ventricular depolarization, so there's 1, 2, 3, 4, 5, 6, 7. Here's the 8th, 9th, 10th, and 11th, okay? What you would do at that point, you would do 11, times 6, okay, and that would give you 66 beats per minute. All right. Now, the actual rate here was 69 beats per minute that the machine gave us. Okay, and you may wonder, why is it 66 and why did we get somewhere between here? So you can see we can get more of a number here. Now notice that there's also a T wave that's occurring here and at the end. So there's actually 11 T waves, or 12 T waves, okay, because we had 11 QRS complexes, but there's this extra one starting here, so it would be 12 times 6, which would give you 72 beats per minute, okay, so you can see that it's pretty much right there, 69 beats per minute between the two, all right. So hopefully that makes sense. Remember, the T wave represents ventricular repolarization, so you can use it to find the ventricular rate. So we found the ventricular rate because we used the QRS complex or T wave. If you wanted the atrial rate, you would use all these P waves here, okay? All these P waves that are preceding the QRS complex and so forth, okay? And in this case, you would get the same answer. That's helpful if we have an AV dissociation or we're trying to find what the underlying rate is of the atrial rhythm, okay? Now, we said that the regularity makes a difference. In this case, we could have used either one to find the rate. Now, if it was an irregular rhythm, whether it's irregularly irregular or regularly irregular, this bottom method, the second one that we used, you can use that one, okay? But this method, this 300 method, okay, there's also a 1500 method for more faster rates. That is only for regular rhythms. So in this case, we could have used both. All right, so hopefully that makes sense. That's the regularity and the rate, okay? And specifically, we found the ventricular rate. So far, we have a regular rhythm. We have a rate of 69 beats per minute, okay? And remember that normal sinus rhythm has a rate between 60 and 100 beats per minute in an adult. And again, we have a 47-year-old male. Okay, so an adult patient. Now we want to ask ourselves, where is the rhythm originating from? Okay, one way to do that is we want to find, is it coming from the ventricles, is it coming from the AV node, or is it coming from the atrial or sinus node? Okay, and what you want to do is look at the QRS complexes. Are they wide? Okay, and wide, I mean greater than or equal to 120 milliseconds, okay, and that's 3 of these small boxes, if you were wondering, okay, so 3 of those tiny small boxes within here. Remember, 5 make up one of these big ones. So is it beyond that? Actually, it's not, okay. The QRS duration in this case was 76 milliseconds. In normal, QRS duration is between 70 and 110 milliseconds, okay, so that's normal. So we have a normal QRS duration, and that will be helpful when we get down here. Okay, it's IV conduction, intraventricular conduction. So it's normal, and I do that because, again, we're trying to figure out where is the rhythm coming from. Is it coming from down here in the ventricles? Okay, imagine this is the right ventricle and left ventricle, right atrium and left atrium. So it's not from the ventricles because we have a normal QRS duration. Okay, is it coming from somewhere here in the AV junction? And in that case, we may not see P waves that precede the QRS complex, or we'll see sometimes P waves that come after that, okay? And in this case, we see P waves that are preceding each one. Okay, you see no drop beats. There's always one P wave preceding it. So it's likely not coming from there. Then we have to ask ourselves, is it coming from the sinus node, okay? Or from an ectopic focus somewhere in the atria? So the best way to do this is ask yourself, is sinus rhythm present, okay? And how do we know if sinus rhythm is present? Well, let's kind of just take a look at this. An easy way to do it is obviously remembering the leads that you should see upright P waves. And when we say is sinus rhythm present, we're looking at the P waves, okay, and their morphology. So remember, the conduction system starts up here. That's our SA node or our sinus node. Comes to our AV node. From there we have our His bundle, then subdivides into our right bundle branch, and then our left bundle branch that has these 2 fascicles, left anterior and left posterior fascicles, innervate the myocardial cells, and then the Purkinje fibers, and then the myocardial cells, the individual ones, and it spreads that way. Now when we're talking about sinus rhythm, we're pretty much focusing up here. Okay, we don't really care so much what's going on down there. And that's why we're focusing on the P waves. Remember, atrial depolarization is, here's our atria, so we're focusing up there. So remember, if normal conduction is heading in this direction, and we have lead 1 here, lead AVL here, we have our inferior leads 2, 3, and AVF, and then we should see upright P waves in those leads. Okay, same thing, our horizontal leads V4, V5, and V6. AVRs back here. Okay, if you don't remember all this or recall it, remember we have over 300 lectures you can go through online to review this. I just don't want to slow down here. So as conduction is moving this way, okay, so conduction is moving, let's use a different color, in this direction, it's going to be positive in these leads, okay, and negative in AVR in sinus rhythm. Okay, so let's look here. Okay, so let me just draw this so you understand it. I don't want to rush through it and you do not understand what we're discussing. So let's just slow down for a second. Okay, and remember we had our sinus node up here, and this is our right atrium. Okay, I want you to imagine that we then have a quadrant system that we have here as well. Okay, and we want to just put our right atrium, which is this one here, on top of this. So this is our right atrium, our sinus node is up here, this is our sinus node, conduction moves in this direction. Okay, if we put our leads now here, here's lead 1, AVL, okay, AVF, our inferior lead, 2, 3, okay, AVRs here, and then we have our horizontal plane where we have V4, V5, V6. Okay, so notice that we have this vector heading in this direction. Okay, positive atrial depolarization vector heading in this direction. We should see upright P waves in these leads here. Okay, mostly over here as it's mostly going that way. Okay, and there should be negative in AVR. So if we look here, AVR, here's our P wave, it's negative. Okay, AVL. It's hard to make out any P waves. We have small QRS complexes. These are QRS complexes that are small. Okay, so hard to make out P waves. You see P waves coming before AVF. There's small ones here in 3, 2 as well, and then here's 1. Okay, and then if we look here at our lateral precordial leads, you see them as well. So negative in AVR and pretty much positive most of the others. Okay, and then if we look through our rhythm strip down here, all these P waves have the same morphology. And notice that there are no drop beats, meaning that there's always a P wave that's followed by a QRS complex. Okay, 1-to-1 ratio. So because of that, the origin of this is sinus. Okay, so we have a regular rhythm right at 69, sinus origin. Now let's find the ventricular axis. Okay, this is an area of a lot of confusion, but hopefully we have an easier one here. Hopefully this will help, reinforce some of those concepts there. Okay, it's really not that difficult, but I certainly see where the confusion comes, and I can remember when learning that was an area of struggle for me. So you are not alone. All right, so let's find the ventricular axis here. So ventricular axis, we're going to focus on the QRS complex or T waves, okay? And we'll find the R axis, which is the QRS complexes. So these ones will use the big complexes that represent ventricular depolarization. Now you have to know that normal ventricular axis is between negative 30 degrees and about positive 110 degrees. So all this is normal axis, okay? This would be a left axis shift. Okay, if it was beyond that, this is a right axis shift, and this is what we call a northwest axis, or no man's land, or right superior axis. Okay, northwest because this is north, this is west, northwest axis. Okay, not many things hang out there. Usually VT will show up there as the depolarization wave heads that way. So this is our normal axis here, and now we need to, so now that we know that, let's just erase this. Actually, I'll leave that there so you can keep that. We can just draw another one. So this is normal. Let's draw another one here so you can refer to that. We have to put our leads on there. So negative 30, and we said positive 110 is normal. Let's put some leads on here. This is lead 1, Lead AVL is here. Okay, AVF is here. So these are the main leads I want you to look at, lead 1 and AVF. Okay, I'll erase AVL because we'll hold on to that one from using it. So lead 1. Okay, here's lead 1. Notice that these QRS complexes are mostly positive above the baseline, meaning that we are going to head towards the positive end of lead 1. Okay, so far so good. Next we look at AVF. AVF is here. Mostly positive QRS complexes will go towards the positive end of AVF. That means our axis lies somewhere between here. Okay, so already we can tell that this is going to be a normal axis. In fact, the axis that we have here is positive 63 degrees, which means the axis is about here. Okay, so it was actually normal, positive 63 degrees. All right, another lead you can look at is lead 2. Lead 2 sits here at positive 60 degrees, and lead 2 is upright and positive, okay, helping to confirm that our axis is normal. Okay, so normal axis here, normal ventricular axis, as we can see here. All right, next let's look at atrial conduction. All right, in atrial conduction, I want to specifically look at atrial abnormalities. Are there any P-wave abnormalities that may suggest atrial enlargement or right or left atrial enlargement? Okay, and you don't see that here. Okay, our P-waves. The best leads to look for atrial enlargement is lead 2 and lead V1. Okay, and our P-waves are what we look at, and they all appear normal. Okay, maybe a little bit here as abnormal, meeting the criteria of left atrial enlargement. Okay, barely. And what do I mean by that? Well, in V1, if you see these biphasic P waves, which are normal, okay, if this, remember, the beginning represents right atrial depolarization. This represents left atrial depolarization. So right atrial abnormalities, we look here. Left atrial abnormalities, we look at the terminal portion, okay, in sinus rhythm, that is. So if this is beyond, if this is 1 millimeter and this is 1 millimeter, that makes the criteria for left atrial enlargement. And maybe you see that here, so we'll put questionable left atrial enlargement, okay. And then for right atrial enlargement, it would be at least 1.5 millimeters in amplitude, going up and down in millimeters there to meet that. Now they're different in lead 2, but we won't get into those details here. Okay, so questionable left atrial enlargement, maybe. Okay, so far we have a regular rhythm. Okay, a rate of 69 beats per minute. We have a normal ventricular axis and questionable atrial conduction representing left atrial enlargement, so maybe. Next, let's look at AV conduction. AV conduction is often we look at our PR interval. Okay, so our PR interval, if we draw my wonderful drawings here that are actually awful, but from here's our P wave, here's our PR segment, this portion here, and then we have our PR interval from beginning up into this point. So this is what I look for AV conduction. Okay, is the PR interval normal, meaning is it between 120 and 200 milliseconds in our adult patients? Okay, remember, it may be shorter in children. All right, so this is normal conduction in adults, which is between 3 and 5 small boxes. Okay, so if you look from here to here, you can see that it's certainly there within normal limits. The PR interval here was 174 milliseconds. Okay, so remember that 120 milliseconds equals 0.12 seconds. Okay, and then 200 milliseconds equals 0.2 seconds. Okay, so some people will use seconds, so just for that. So we have a normal PR interval. Okay, also look, are there any dropped beats? We said that each P wave has a QRS complex that follows it. All right, and we have no dissociation. There's always that P wave coming at the same time prior to it, so no dissociation, no evidence of AV blocks here. Next, I look at IV conduction, and we've kind of already touched on that. That's the QRS duration. In this case, the QRS duration was 76 milliseconds, which we said was within the normal limits of between 70 and 110 milliseconds. Okay, sometimes if that is prolonged, but you don't have any evidence of morphologic evidence of a bundle branch block, we may call that an intraventricular conduction delay. So IV means intraventricular, AV is AV atrioventricular. Okay, so IV conduction is normal here. We have no evidence of any bundle branch block. Next, we want to look at the waveforms, and here that would be any problems in that we've missed. So are there any Q waves that we see here that we should point out? Not so much. There is some small amplitude that we see in AVL, okay, something to note, but otherwise I don't see anything. Are there any ST segment changes we should be aware of? Not so much, but there is this wave coming here at the end, okay, so you may notice that. That's an interesting wave. We said our 47-year-old male came in unresponsive. This is something that we call a J wave or an Osborn wave, okay, and that's something I'm going to put here, an Osborn wave, okay, or a J wave, meaning it's coming right at the end near our J point, okay. This is a positive deflection at the J point, okay. It may be negative in AVR and V1. We don't see that here, okay, and this is an actually important thing that we'll discuss shortly. All right, so anything else? Okay, no ventricular ectopic beats, no inverted T waves that we should point out, no ST depression or elevation that we see here, no PR depression or elevation that's significant. So not much else going on here. All right. How about anything else? This is something that I use if there's something that's glaring that I've missed, or just a chance to review it again. Then I'll look at R wave progression, okay? And that's R wave progression. These last two things have to do with these precordial leads. And again, this is an imperfect science of putting leads on patients, so it's not an exact science that we can always trust, but something that can be helpful, especially in an area where you know that you have pretty good techs that are placing these on. So R wave progression, the normal R wave progression from V1 all the way as we get to V5 should increase. So our R waves, okay, they should increase in amplitude, all right, as we go from right to left across the precordium. And the R to S ratio, so the R to S, so R wave and S wave, should actually increase, in which the R wave goes up and the S wave goes down. Okay, so there should be an increase in the R to S ratio. And this is pretty much normal here. Okay, a little slight delay here between V2 and V3, but overall I would say normal R wave progression, nothing significant to point out. And then transitional zone, that's where we go from being mostly positive here in the precordial leads to being mostly negative, okay? So you can see that it's mostly negative, negative to mostly positive. So mostly negative here. Let me erase that so you can see what I'm talking about. So and we'll erase this down here. So this is where we're going from mostly negative. Okay, so you can see it's negative, mostly negative, and then positive. So normal transitions between V3 and V4, so going from mostly negative to mostly positive, and it's normal here. Okay, so that's a normal transitional zone in the precordial leads. If it were to come before, meaning become positive maybe here, okay, and then this negative, that would be an early transition, or we would call that a counterclockwise rotation, okay? And if it were to come after V4, we would call that a late transition, and that would be a clockwise rotation, okay? All right, so now that we have all that information, what we do now is take this into context, okay? And this is a regular rhythm, rate at 69, sinus rhythm. That means we have a normal sinus rhythm, okay? Normal access, questionable left atrial enlargement, okay, normal PR interval, AV conduction, IV conduction. We have these Osborn waves, okay, or J waves that we're going to point out, and otherwise everything else is normal. Compared to the previous ECG, the Osborn waves are new, and it was normal sinus rhythm and a rate of 75 beats per minute, so I'm not off there, but the Osborn waves were not present before. Okay, so this is new. So what do we know about Osborn waves? Well, we have a 47-year-old male, unresponsive on the street. Osborn waves, okay, his temperature is something that can help tell you the severity of these. Okay, so Osborn waves are positive deflections at the J point. They can be negative in AVR and V1, and they're prominent mostly in the precordial leads. Okay, and the amplitude is proportional to the degree of hypothermia. So how cold? Okay, this patient was very cold, had a temperature around 33 degrees Celsius. Okay, so very cold, but in that mild range. Okay, there were no ventricular ectopic beats that we can see or arrhythmias that can come with hypothermia, so that's reassuring. The PR interval is normal, so in hypothermia you can see an increase in the PR interval, the QRS interval, and QT interval. Actually, one thing to note is this guy's QTC, I forgot to mention, was 506 milliseconds. Okay, so QTC is corrected QT interval. So this is a slightly prolonged QTC that we should note here. Okay, so slightly prolonged above 500, and something we should be aware of, putting the patient at risk of sometimes ventricular arrhythmia, such as torsades, if it gets too long. So it's just something to note. So hopefully that makes sense. The Osborn waves is something that's interesting that I wanted you to certainly see here, and that's these ones here coming in. Okay, you don't always see them too often, so it's good if you get a chance to keep them in mind. Those are also J waves, and we can see those in J wave type syndromes. Okay, so that's the end of this EKG. Okay, again, a 47-year-old male, unresponsive on the street, and coming in is the final interpretation is normal sinus rhythm. Okay, questionable left atrial enlargement, Osborn waves, and a prolonged QTC interval when compared to prior the Osborn waves, and actually the prolonged QT is new. Okay, so that's it, and hopefully you learned something here. Now I want to make you aware of our EKG coding reference that many of you are already using. How to get access, okay? So you want to go to this link here. So put in that link into into the computer, into your internet source, and then go to put your email address here when you get to that, and then you're going to use my password here to put in there. Make sure you're using my password every time, okay? And let me just erase here. So this one here, all lowercase, put that in, and then click submit. Confirm your email. So check your email, get a confirmation, and you'll have access. Okay, and access here will be this, and you'll start to see that we have examples, and I'm now adding videos into it. So this is an on-the-go reference, has everything you could possibly imagine we use as we're building the course for our fellows here at Mayo Clinic, and so forth. So I think it's quite handy. Our techs are using it. We're using it for coding here as well. So very helpful way to learn, to use as a reference, and so forth. Okay, and you'll see a lot of the things we discussed in this lecture there as well. All right, so a few things. If you thought this was helpful, if you did, yes or no, I would like to know how I can improve, what kind of topics you want. Please leave them below. Like this video if you find this helpful, and share with friends. If you want more practice, okay, obviously more practice is on our Facebook page, where there's almost 500,000 of you there, and thank you for your support. We have daily questions, trying to get back to you between our clinics and making sure we're staying in touch. So go there for practice. There's daily practice. I leave resources. You can find us on Twitter, search the EKG Guy, YouTube, obviously, and Facebook. Okay, it's hard to keep up with all these things, so find us there, share with your friends if you find this helpful, and please leave a comment if there's any topic, or just kind words. We always appreciate it, and I hope you learned something today. Well, thank you for making us the largest, fastest growing EKG community in the world.